Good afternoon, everyone, and welcome to our 2021 inaugural Garth and Graham Distinguished Lectureship Award. My name is Daniel Dawes, and I'm the Executive Director of the Satcher Health Leadership Institute at Morehouse School of Medicine. Before we begin, I'd like to thank the audience joining us today via Zoom and YouTube. We welcome you to use the chat function to network with each other, but please note that we are not taking any questions from the chat during today's session. So now it is my pleasure and honor to present today an award that is so meaningful, not only to myself, but to our institute and to our founding director, the former 16th U.S. Surgeon General, Dr. David Satcher, and hopefully to all the Trailblazers who have battled long before us, helping to pave the way for a more just and equitable future. You see, with the COVID-19 pandemic, while it's ravaged our communities, disproportionately, we must recognize that some good has emerged from it. And that is that we have reached an inflection point in our country's history. If nothing else, the virus has served to highlight the degree to which our most vulnerable communities have been impacted, all because they stood on an inequitable foundation. As a result, conversations are now being held at high levels regarding many issues that were once considered too taboo to be acknowledged, much less mentioned at these roundtables. By acknowledging their existence, we are beginning to address the true drivers of the abundant inequities and injustices found not only within our healthcare system, but in our society at large, that have created political, social, economic, and mental disadvantages, specifically for communities of color. You see, while health equity has gained some momentum, it's important that we continue to keep this topic at the forefront of our agendas so that we can create a brighter and healthier future for all Americans. This award is an embodiment of just that, an unstoppable, transformative force for health equity, creating systemic change through heroic action and bravery in their own right. The Garth and Graham Distinguished Lectureship seeks to spotlight trailblazers who are leading the creation and advancement of health equity, not only domestically, but internationally. This lectureship is named in honor of Dr. Garth N. Graham, who during his tenure at the U.S. Department of Health and Human Services yielded incredible influence as the Deputy Assistant Secretary for Minority Health, championing and successfully leading the development of seminal reports, programs, and public policies intended to elevate health equity in the United States. In September of 2008, he released the HHS report, Assuring Healthcare Equity, a healthcare equity blueprint, which laid the foundation for the 62 health equity focused provisions of the Affordable Care Act, or Obamacare. You know, the truth be told, we would not have been successful in our advocacy efforts to advance a health equity agenda into health reform negotiations without this blueprint. Once the ACA was signed into law by President Obama, Dr. Graham wasted no time in implementing these provisions. And he recognized that for the nation to meaningfully eliminate health disparities, we needed a national action plan. Despite internal and external challenges, he led the development of the first comprehensive action plan and community stakeholder strategy to eliminate health disparities across the country. He also led the development of the first national set of data standards for disability, race, ethnicity, and primary language, and worked tirelessly to expand the number of state offices of minority health throughout the United States. His courageous actions and dedication toward advancing health equity inspired us to create this lectureship. A trained cardiologist and professor of medicine, Dr. Graham is passionate about the opportunity to improve local health through cross-sector collaboration. He is a leading authority on social determinants of health and health equity. He's also, as a former vice president and chief community health officer for CVS Health, Dr. Graham led the enterprise-wide social determinants of health strategy, working closely with CVS Health's many businesses to ensure differentiated, measurable, and scalable approaches to addressing social determinants of health in communities across the country. And now, today, Dr. Graham serves as the director and global head of healthcare and public health at Google and YouTube, where he is tasked in helping to expand opportunities in technology to support public health and our healthcare system overall. Won't you please join me in thanking and congratulating Dr. Garth Graham for his exceptional leadership and advocacy. Dr. Graham, the floor is yours.
Thank you, Daniel. And firstly, let me just start off by saying how deeply, when I say deeply humbled I am, that this award, this lectureship, everything this means, and what it means for, I think, future trainees and other young folks who are coming through and blazing paths that you have blazed already, Dr. Dawson, and everything else that has happened in this terms of this fight against health equity and just a long struggle. There are two people who come to mind when I think about this award. Congressman Luke Stokes, who many years ago, along with Congressman Donna Christensen and members of the Congressional Black Caucus, really put so much work into laying the foundation, a legislative and on a policy end, around health disparities and health equity, and I think whose shoulders many of us stand on. I also stand on the shoulders of my parents. My dad taught me so many things when I was growing up, and we would drive and be talking, and he'd all be talking about politics and policy. And what he was doing there, I think, was putting in my mind, and I think in his kids' minds, kind of the breadcrumbs of what's needed. I think raising particularly children, particularly Black men, can be challenging. I think, understanding how we become who we are and have an impact in a world that many times, faces and gives us all kinds of resistance in so many different ways. And so I wanted to dedicate this award to my dad, who didn't know this until about 15 minutes ago. He's actually sitting right beside me. Here's my dad. For just everything he's done, in bringing us to this point. And I think underscoring the examples of mentorship and leadership. And I think everything that we're hopefully embodied with this lectureship and the leadership of Dr. Williams and so many others. So just thank you from the bottom of my heart on a very humble note, but also, just recognizing the footsteps of giants, whether they're giants who are sitting beside you, as my dad is, giants like Dr. David Williams, or other giants, I think, in the public policy and health disparities arena, who have really just set us forth on a trail to hopefully lead to a healthier America. So again, thanks to Dr. Satcher, thanks to you, the leadership at the Satcher Leadership Institute, leadership of Morehouse, the leadership from the folks at the University of Texas, University of North Texas, as well as others, for really just establishing this and allowing us to raise the voices of current and future healthcare leaders around health disparities across the globe.
Well, Dr. Graham, thank you so much. And I hope you know the feeling is mutual. And thanks, of course, to Daddy, Father Graham, for, your influence on this. I mean, obviously, your fingerprints are all over the successes that we've achieved in this health equity movement. So thank you again, Dr. Graham, and to Father Graham. At this time, I want to introduce to you now and invite to provide remarks our amazing partner who helped to make this lectureship possible. The University of North Texas Health Science Center's sixth president, Dr. Michael R. Williams. He is an anesthesiologist and critical care physician who has worked assiduously to bolster patient safety and improve health outcomes throughout his tenure. It is such an honor to have you join us today, President Williams. Would you all join me, please, in celebrating and welcoming Dr. Michael R. Williams? Dr. Williams, the floor is yours.
Thank you, Daniel. Hello to everyone. And thank you, Dr. Graham. Especially to a special comment to Dr. David R. Williams, and congratulations on earning the distinction of receiving the first ever Garth Graham Distinguished Lectureship Award. It's really my honor and privilege to be a part of this inaugural lectureship series event. This work we're discussing and the work that Dr. Graham and Dr. Williams have dedicated their life to is work that I personally feel called to be a part of. So it's inspiring to be surrounded by incredibly talented individuals who are helping change the world by improving the lives of others through innovative healthcare solutions. At the University of North Texas Health Science Center at Fort Worth, it's actually timely because this is our mission. This is our mission statement, to create solutions that improve the lives of others. HSC is a community leader in the North Texas area, working to bring local, state, and global attention, as well as national, to the serious issue of health equity. This meaningful mission is taking place as our institution works to educate a future healthcare workforce that includes empathetic doctors, physician's assistants, physical therapists, pharmacists, public health professionals, and many others, who are all collectively committed to a much better future for everyone. We cannot solve these serious inequities that impact our communities daily unless we all work together. That's why for our university, it's especially critical that we come to this meeting and get the honor to be a part of this, because two of our core values are serving others and collaboration. And this work cannot be done unless we educate collaborative and service-oriented healthcare providers. And it's imperative that we lift up those doing the hard work and highlight their dedication to improving the lives of those disproportionately impacted by health disparities. And to Dr. David R. Williams, his dedicated life work is just to this exact work. He has worked diligently throughout his career to help continue the difficult conversation around health equity, and we celebrate that dedication today. And lastly, it's truly an honor to be representing HSC as we participate in the celebration of this inaugural event, and specifically to recognize the many contributions of such great leaders as Dr. Graham and Dr. Williams. And lastly, a special thank you to our partners at the Satcher Health Leadership Institute at Morehouse School of Medicine and YouTube for making this come to fruition and recognizing the unsung heroes that are changing the world for generations to come. Thank you very much.
Well said, President Williams. Thank you for those remarks. We are really, like I mentioned, very honored to have the Health Science Center as a key partner in this effort to educate and bolster health equity nationally and internationally. So thank you again for your leadership and to the leadership and the scholarship at your institution. So let me now recognize our distinguished speaker today. Staying true to our vision of spotlighting trailblazers, the first recipient of our 2021 Garth Graham Distinguished Lectureship is a renowned public health scholar, researcher, leader, and speaker. He's a professor of public health and chair of the Department of Social and Behavioral Sciences and professor of African and African American Studies at Harvard University and the Harvard T.H. Chan School of Public Health. Of course, I speak of none other than the brilliant Dr. David R. Williams. His research on the social influences on health has helped us to understand the complex ways in which socioeconomic status, race, racism, stress, health behavior, and religious involvement can affect health. He has authored more than 475 scientific papers, and he has served on the editorial board of 12 scientific journals and as a reviewer for over 75 others. This internationally recognized social scientist developed the Everyday Discrimination Scale, which is now the most widely used measure of discrimination in health studies. Under the sponsorship of the World Health Organization, Dr. Williams directed the South African Stress and Health Study, the first nationally representative study of the prevalence and correlates of mental disorders in sub-Saharan Africa. He was an integral key member of the team that conducted the National Study of American Life, the largest study of mental health disorders in the African American population in the US, and the first health study to include a large national sample of Blacks of Caribbean ancestry. It is not surprising then that he has been invited to keynote scientific conferences on almost every continent, including ours. So nationally, Dr. Williams has been involved in the development of major health policy. He has served on the National Committee on Vital and Health Statistics and on 9 committees for the National Academy of Medicine, including the committee that prepared the landmark Unequal Treatment Report. His groundbreaking research is what Dr. Graham used, as we mentioned earlier, to develop the seminal reports and what we have used to advance equity-focused public policies relative to health reform, mental health, housing, and in tackling the multiple complex determinants of health, including the political determinants of health. He's also served as a member of the MacArthur Foundation's Research Network on Socioeconomic Status and Health. You see, Dr. Williams has played a visible national leadership role in raising awareness of the problem of health inequities and identifying interventions to address them. He served as the staff director of the Robert Wood Johnson Foundation's Commission to Build a Healthier America. This national, independent, and nonpartisan health commission was focused on identifying evidence-based, non-medical strategies that can improve the health of all Americans and reduce racial and socioeconomic gaps in health. He has also worked on ethnic inequities with the Toronto Public Health Department and the National Health Service in the United Kingdom, as well as with the Pan American Health Organization. It is now with great esteem and admiration that I present our inaugural 2021 Garth and Graham Distinguished Lectureship to Dr. David R. Williams, ranked by Thomson Reuters as one of the world's most influential scientific minds, for his life's work, relentless dedication to improving the quality of life for our most vulnerable populations, and for advancing health equity and health justice overall. Dr. Williams, welcome and congratulations. Thank you so much for joining us today.
Thank you so very much. I am truly deeply honored by your kind words, by the award. I appreciate the scholarship that you have done that has also inspired me, the seminal work that you have done. I have followed with great admiration the career of Dr. Graham as well. So it's truly, I'm humbled by the opportunity, and the colleagues from the University of Texas, I'm truly humbled by the opportunity to be a part of this program and to continue the legacy of Dr. David Satcher and the Satcher Leadership Institute, as he has been such a champion of health equity throughout his distinguished career. So I'm humbled and honored to be a part of this program. I want to talk today about what the challenges are that we face and what we can do together to build a healthier America for all. I want to begin by talking about a tragedy that grabbed the attention of the world when Malaysia Airlines Flight 370 disappeared from the sky and triggered a global search for this jumbo jet, trying to understand what had possibly gone wrong. It was a search that lasted 3 years. In just the first month, 19 ships were deployed, 345 sorties by military aircraft searched for this missing plane. Sonar searches were conducted underwater, and the underwater searches alone cost US $155 million. So I'm talking about a tragedy and an appropriate response to that tragedy. I want to talk today about a second tragedy, a tragedy that is captured in racial and ethnic inequities in health. And I will give you one example of that, and that is the differences that exist in the United States by how long someone lives. We call that life expectancy by race. And for blacks and whites, we have the data going back to 1950. And you could see that in 1950, the average white person lived 8 years longer than the average African-American person. And in 2020, there is still almost a 6-year gap in life expectancy. The good news is life expectancy has increased for whites over time. Life expectancy has increased for blacks over time. But the size of the gap and its persistence is in fact very troubling. Look at the statistics on this chart. Life expectancy for whites in 1950 was 69.1 years of life. And if we ask the question, how long did it take for African Americans to experience the health that whites had in 1950, you would see it was not until 1990. 40 years later, two groups living in the same society. And the 6-year gap that we have today, if the health of African Americans increased at the same rate at which the health of the United States has increased for the last 10 or 20 years, it will take 30 to 40 years to eliminate that gap if we froze the life expectancy of whites. So we have a tragedy here. And to talk about racial differences in health and life expectancy differences is not very concrete. So I want to make it concrete, and I want to rely on a paper that was published years ago that showed, if we look at that black-white gap in life expectancy, and we broke it down to how many black people die every year who wouldn't die, and we break it down further to every day, it's over 200 black people die prematurely every single day in the United States. Imagine a fully loaded jumbo jet taking off from your nearby airport with 220 passengers and crew and crashing today. That would be a tragedy. It would be major national news. But it also happened tomorrow, and every day next week, and every day next month, and every day for the year. That is what we're talking about when we are saying there are racial inequities in health, and the statistics I just shared captures only the excess deaths for the African American population, doesn't capture the deaths for all the other groups that are adversely impacted. And COVID-19 has been a wake-up call for many Americans. This slide shows the age-adjusted odds ratios. Let me tell you how to interpret this. We are looking at the death rate of whites, and we're comparing the rate of death for other populations compared to the rate of death for whites. So the Native American population has died from COVID-19 at a rate 3.3 times greater than that of whites. Latinos, 2.4 times higher death rate. African Americans, a death rate twice as high. Pacific Islanders, 2.6 times as high. These are striking, stunning numbers, and I'll show you the consequences in a minute. However, I have found as I speak about COVID-19 that some Americans think because the death rate is higher for populations of color, that most of the people who have died are populations of color. No, COVID-19 has adversely impacted the entire population of the United States. And if we look at deaths just through March 2, 2021, more than half of the deaths of persons who have died, 300,000 almost, were to the white population compared to almost 90,000 Latinos and 73,000 African Americans. And recent reports indicate that COVID-19 has had an impact, a negative impact on the African American and other populations of color that we have not seen since the Second World War. The life expectancy at birth from 2019 to 2020 because of COVID-19 has declined by over 3 years for African American and Hispanic males, for over 2 years for Black and Hispanic females, and for over 1 year for white males and females. That is a massive decline that we are observing. And so we are left with the question, what drives these large racial inequities in health? And the first thing I would think of is, well, there are large inequities in health by socioeconomic status. When I use the term socioeconomic status, I'm talking about differences by income, by education, by occupational status, and by wealth. And to give you an example of those differences, here is a study with national data for the United States and the relative risk of all-cause mortality by income level. And what you see is that low-income Americans with incomes less than $25,000 is about where the poverty rate is in the United States today, are 3 times more likely to die. The overall death rate is 3 times higher than it is for high-income Americans, and every higher level of income is associated with a lower death rate. Well, that's a clue, because there are large racial ethnic differences in socioeconomic status. Here is the data for the United States in 2018, household differences in household income by race ethnicity. I want to translate the numbers on this slide into a way in which you can readily understand it. I'm standardizing on the household income of white households as $1. And I'm saying for every dollar of household income that white households receive, how do other racial groups do? Well, Asians receive $1.23. That has to be contextualized by realizing that Asian households are more likely than those of other groups to be multi-generational and to have more persons contributing to household income. Asian households, Asian Americans have a very high rate of immigrants. Almost 70% of Asians are immigrants who have come to the United States with high levels of education. But let's look at the historically disadvantaged groups. For every dollar of household income white households receive, Latino households receive 73 cents, Native American households and African American households 59 cents. That's data for 2018. Do you know what is stunning about a 59 cents figure for African Americans? That is identical to the black-white gap in income in 1978. You heard me correct. I did not misspeak. In 1978, the peak year of the narrowing of the black-white gap in income as a result of the anti-poverty policies and the civil rights policies of the 60s and 70s, the gap had been narrowed to 59 cents. And in 2018, it is still 59 cents. Has it been stuck at 59 cents over time? No. It got worse throughout the decade of the 1980s, and it was not until the mid-1990s it got back up to 59 cents. And it's been a penny up and down since then. And the differences by race in income dramatically understate the racial differences in economic status. And I am first going to illustrate the differences by poverty that tells the same story. If you look at the poverty rate in the United States in 2018, you could see 1 in 5 African Americans are poor, 10% of Asians and 8% of whites are poor, 25% of Native Americans are poor, and almost 20% of Latinos are poor. However, because the populations vary in size, the majority of poor people in America are whites, almost 16 million poor whites compared to almost 11 million poor Latinos and almost 9 million poor African Americans and 2 million poor Asians and 700,000 poor Native Americans. So when I talk about socioeconomic status and its impact on health, I'm talking about every racial ethnic group in the United States. But these large racial gaps in income understate the racial gap in economic status. And what do I mean by that? Well, income captures the flow of resources into the household, but it does not tell us much about the economic reserves that households have to cushion shortfalls of income. We get that from data on wealth, which captures our home equity, our savings, our investments, the other financial resources and instruments that we have. And the Federal Reserve Board tells us that for every dollar of wealth that white households have, African American households have 10 pennies and Latino households have 12 pennies. What does this mean? It means that although we are in the storm of this pandemic, we are not all in the same boat. And some boats are better able to weather the storm than others. When you are low in economic status and you are low in wealth, you're often one paycheck away from being homeless or one paycheck away from being able to feed your family. When my career started, most researchers thought that racial ethnic differences in health were simply a function of differences in income and education. We now know that life is more complicated than that. I want to illustrate that for you with national data for the United States. Life expectancy at age 25. At age 25, how long will the average person live? Well, the average white person will live 5 years longer than the average African American. So there's a 5-year racial gap in life expectancy at age 25 in the United States. But if we look within the white population, by education, the same is true by income. Whites with a college degree or more education live 6.4 years longer than whites who have not finished high school. That socioeconomic gap within whites is bigger than the black-white gap, and we see something similar within African Americans, a 5.3-year gap between blacks with the highest level of education and blacks with the lowest level of education. But at the same time, at every level of education, race still matters. So white high school dropouts live 3.1 years longer than black high school dropouts. And amazingly, the gap widens as education increases, with a 4.2-year gap between black and white persons with a college degree or more education. And here is the most stunning statistic I'm sharing with you today. National data for the United States. The best off African Americans, those with a college degree or more education, still have lower life expectancy than whites with a college degree, than whites with some college, than whites who have finished high school. So what are these data telling us? They tell us profoundly that there is something about income and education that matter for your health, regardless of your race. But there's something else about race that matters even after we've taken income and education into account. And researchers have been asking for the last quarter century, could racism be a critical missing piece of the puzzle to understand the patterning of racial disparities in health? And I want to talk briefly about how structural and institutional racism contributes to racial inequities in health. I want to illustrate that by looking at residential segregation, a striking example of upstream racism that is a major contributor to racial inequities in health. A historian from Duke University who wrote a book about segregation called it one of the most successful domestic policies of the 20th century in the United States. But before we unpack segregation and how it works, let's understand how Americans think about racial inequity in health and what drives racial inequities in health. A study was conducted in 2018, national data for the United States, and the study found that among Americans, 42% of Americans believe that all racial inequities in health and other domains of life would just disappear if blacks only worked harder. Blacks would do as well as whites, they said, if they only tried harder. So they saw inequities as a failure of African Americans to work hard. And there was a striking political divide on that question, with Republicans much more likely to say that the failure to work hard was the cause of inequities in our society than Democrats were. I'm just reporting the findings, not making value judgments. What does the scientific research clearly say? Well, this research says that segregation is the central driver of the large racial ethnic differences in socioeconomic status and in opportunity to American society. Think of it this way. This is a summary of the science. I'll show you some specific studies in a minute. Imagine segregation is like a burglar at midnight. It slips into the community, and as soon as it shows up, valuables disappear, like quality schools, and like safe playgrounds, and good jobs, and a healthy environment, and safe housing, and good transportation, and access to high quality medical care. All of these are patterned by place in the United States. And that's why public health officials now say that your zip code, where you live, is a more powerful predictor of your health than your genetic code. But let's look at some of the scientific evidence. I'm drawing here on the work of Professor Dolores Acevedo Garcia at Brandeis University. She has created a neighborhood opportunity index that ranks every county in the United States on almost 30 different indicators of access to opportunity. Things like the quality of elementary schools, and the income level and home ownership rate and employment rate, and exposure to air, water, and soil pollution and hazardous waste sites, and access to resources for health like healthy food and walkability. And what she finds, if you look at the 100 largest metro areas in the United States, this is a 2020 study, she finds that 2/3 of all Black children, 58% of all Latino kids, 53% of all Native American children in the 100 largest metro areas are growing up in very low and low opportunity neighborhoods compared to 1 in 5 white and Asian children. If you look at who lives in the high and very high opportunity neighborhoods, almost 2/3 of all white children and Asian children, and about 1 in 5 Black and Latino kids. So access to opportunity at the neighborhood level is a huge driver of inequities in the United States. And in fact, the research finds that segregation contributes to large racial ethnic differences in socioeconomic status. Here is a colleague of mine, Dr. David Scuttler at Harvard University. He did a study, national data of Blacks and whites, young people making it in the labor force. And he shows statistically, if you could eliminate residential segregation, you would completely erase Black-white differences in income, in education, and in unemployment, and reduce Black-white differences in single motherhood by 2/3. All of these striking differences are linked to opportunity at the neighborhood level. Another Harvard economist, Raj Chetty, asked an intergenerational question. He said, let's begin by looking at Black and white boys who begin life in households with the same level of family income. How are they doing in the next generation? And he finds that Black boys have lower earning than white boys in 99% of census tracts in America. Why? They live in neighborhoods that differ in access to opportunity. Black boys do as well as white boys in neighborhoods with good resources. The challenge is there's only a very tiny number of Black children who live in such good neighborhoods in the United States. So what am I saying today? The research is telling us that the racial ethnic inequities in socioeconomic status that matter for life and health do not reflect a broken system. Instead, they reflect a carefully crafted system functioning as planned, successfully implementing social policies, many of which are rooted in racism. The inequities we see are not accidents, are not acts of God, are not the failure of people to work hard. They illustrate the ways in which racism has produced a truly rigged system in the United States. To give you one more example of it, 2 Harvard scholars, William Julius Wilson and Robert Sampson, show that in the 171 largest cities in the United States, there's not even one city where whites live under equal conditions to those of Blacks, and that the worst urban context in which whites reside is considerably better than the average context of Black communities. And research finds that when you are of lower income, living in disadvantaged segregated neighborhoods, you are exposed to higher levels of stress and a greater clustering of economic stresses and psychosocial stresses and physical and chemical stresses. So I've talked about the ways in which segregation is creating inadequate access to opportunity and leading to higher levels of stress. It also affects access to medical care. If you have Black and brown low-income populations concentrated in poor communities, there are elevated levels of pre-existing illnesses and poorly controlled chronic disease. In these communities, there's a shortage of primary care providers and a very severe shortage of healthcare specialists. This results in delays in getting optimal care in the United States. I want to illustrate that with the South LA, where there is a wonderful center that is providing care to this segregated community and showing the ways in which care is underfunded in the United States. The average emergency room visit in Los Angeles earns about $2,000 from a commercial insurer, about $650 from Medicare, but only $150 from Medicaid. The type of insurance that most of the residents have. And safety net hospitals receive a little supplemental funding, but there are no supplements for most outpatient and community-based care. So what am I saying? The historic underfunding of care for communities of color, for persons who reside in disadvantaged communities, is a problem all the time, but gets worse during pandemics. And it's a contributor to the racial, ethnic inequities in health that we see. And then, in addition to segregation and upstream measures of discrimination, there is individual level discrimination that is also a source of toxic stress. Professor Dawes mentioned my everyday discrimination scale that I developed that captures not all aspects of discrimination, but just the little day-to-day indignities. Being treated with less courtesy and respect than others, receiving poorer service than others at restaurants or stores, people acting as if you are not smart or if they're afraid of you, or they think you are dishonest or they are better than you are. Just to illustrate the power of the findings, I'm showcasing the work of Dr. Tenny Lewis from Emory University in Atlanta. And each line on this slide reflects a different study, and it's just some of the studies she has done linking everyday discrimination to health. Higher levels of everyday discrimination links to more rapid development of heart disease as captured by coronary artery calcification, to higher levels of inflammation, to higher levels of blood pressure. Pregnant women who report everyday discrimination give birth to lower birth weight infants. Elderly who report everyday discrimination have more rapid declines in cognitive function over time. Higher levels of everyday discrimination is linked to poorer sleep. A study of adults followed over time, everyday discrimination is an independent predictor of premature death. Those little indignities are killing populations of color slowly in the United States. And a final study that I'm illustrating, a study of everyday discrimination among Black and white women in the United States, is linked to higher levels of visceral fat, the deep internal abdominal fat that increases our risk for so many chronic diseases. And what's the consequences of all of these stressors and discrimination on top of that? Scholars are talking about accelerated aging and premature aging and biological weathering and the earlier onset of chronic disease. And what they're using these fancy terms to capture is that research is documenting that African Americans and other populations of color are literally aging biologically more rapidly than whites. Because when you live in a bad environment, exposed to all these stress, your age is not only capturing how long you have lived, it's also telling us how long you've been exposed to bad environmental conditions and how physiologically compromised you have become from those exposures. And to give you one example, here is data, national data from the CDC. And by age 50 to 64, 61% of African Americans have high blood pressure, compared to 41% of whites. I've talked about the challenge. What can we do? The first big strategy is we need to build more health into the delivery of medical care. We can do this by ensuring access to high quality care for all. I want to give you an example of what was done in the state of Delaware. There was a huge racial gap in colorectal cancer, and they decided to develop a colorectal cancer screening program and make it available to everyone in the state who had incomes below 2.5 times the poverty level. And then they added not only screening for colorectal cancer, for treatment. The program started in 2002. And by 2009, they had eliminated the racial gap in colorectal cancer screening by increasing the rates for African Americans and increasing the rates for whites. They also had eliminated the racial gap in new cases, the incidence of new cases of colorectal cancer, again by declining rates for African Americans and declining rates for whites. And most dramatically of all, they had nearly eliminated the gap in death rates from colorectal cancer. And what is most mind-blowing about this, they did all of this great work and it saved the state money. The savings led to a $1.5 million per year saving because of the reduced incidence of colorectal cancer disease and earlier diagnosis. Medical care alone will not solve every health disparity, but we need to put it to work and save money in those cases when it can make a huge difference. What else do we need to do? We need to ensure high quality care of all. The unequal treatment report was mentioned, report from the National Academy of Medicine in 2003 that documented across virtually every therapeutic intervention, African Americans and other populations of color receive poorer quality care than whites. It continues. Here is a paper published last year of 1.8 million hospital births in the state of Florida. And what did it find? When cared for by white doctors, Black babies are 3 times more likely than white newborns to die in the hospital. This disparity is cut in half when Black babies are cared for by a Black doctor. So one of the take-home messages is that we need to diversify the workforce to meet the needs of all patients. And there is high-quality scientific evidence that if we have racial concordance between the patient and the provider, we can maximize engagement and the quality of care. Here is a randomized controlled trial, a fancy name for a very sophisticated, high-quality scientific study, where African-American men in Northern California were recruited to take part in this Saturday clinic at a nearby medical center. They would be screened for blood pressure and BMI and cholesterol and diabetes. When they got to the clinic, the men were randomized to see a Black doctor or not. And what the study found was those African-American men who saw a Black doctor were 29% more likely to talk about other health problems, 47% more likely to do screening for diabetes, 56% more likely to get a flu vaccine, 72% more likely to do screening for cholesterol. In other words, they engaged more with the healthcare system. We have, as a nation, a challenge. In 2014, there were fewer African-American males in the first year of medical school across this great nation than in 1978. In the mid-1960s, 2.9% of all practicing physicians in the US were Black. In 2019, 5% of physicians were Black, 6% were Latino, 0.3% were Indigenous. We have a long way to go, but we need to start working now so that we can make a difference. What else do we need to do in the healthcare space? We need to provide care that addresses the social context. The World Health Organization asked the question, what do we accomplish if all we do is treat illness and send people back to live in the same conditions that made them sick in the first place? And we have many examples of programs that take a broader view of the patient. One is the nurse-family partnership model that would send nurses to make home visits to vulnerable pregnant women. And they would talk about their pregnancy, but they would also talk about their employment, their future, their relationships with their partner, about parenting. And they would continue those home visits into the first year of life. And what did they find? This program improved the health of mothers, improved the health of their babies and infants, And for every dollar of every patient served with this program, there's a return to society. It literally saves society money. Another example is the Medical Legal Partnership, a program born at the Boston Medical Center, where a primary care provider in the pediatrics unit could refer a patient to a number of specialists. One of those specialists was an attorney. Yes, the hospital has on-site attorneys to solve the problems in the lives of their patients. Imagine a mother coming to a pediatrician with a child with asthma, and that asthma is secondary to the housing conditions that they face. All the asthma medication in the world will not help that child to breathe symptom-free if that child goes back to live in the same conditions that made them sick in the first place. But the intervention of a lawyer can make a difference. So we've talked about interventions in healthcare, but interventions in healthcare alone are not enough. We need to create communities of opportunity to minimize, neutralize, and dismantle the systems of racism that create inequities in health. I'm saying we need place-based initiatives that enrich the quality of neighborhood environments, increase economic development in poor areas, and improve housing quality. There's a long list of things we need to do, like reducing childhood poverty and enhancing income and employment opportunities and enhancing economic opportunities to produce strong families. But I want to highlight just two of them in the interest of time. One is investing in early childhood, and two is improving neighborhood and housing conditions. The Carolina Abacidarian project, a project born in Chapel Hill, North Carolina, that has now been replicated around the world. They took poor children, 80% of them African American, randomized them at birth to receive an early childhood enhancement program with good nurturing, good intellectual stimulation, good nutrition, good pediatric care. By age 21, they're doing better in health and better educationally and better in jobs. By their mid-30s, they have lower levels of risk factors for heart disease and cardiometabolic disease. So for example, look at the differences in systolic blood pressure in the mid-30s between the treatment group, those who got the program, and those who didn't get the program. Striking differences in blood pressure, but also on many other markers of metabolic disease. It can be done, and these programs save society money. The second example is we can improve neighborhood and housing conditions. And I want to give you the example of purpose-built communities and the first purpose-built site in Eastlake, Atlanta. Come with me in 1995 to Eastlake Meadows in Atlanta. Here is an African-American public housing project with a very high rate of crime, a place where the units are very dilapidated, where only 13% of adults are employed, and where the local elementary school is one of the worst performing in the state of Georgia. But the community leaders came together with the public housing department and with a wealthy philanthropist and created purpose-built communities that is now being replicated across the United States in many sites. And what is the transformation we see there? A 90% reduction in violent crime, a high-quality, privately managed housing. Half of the residents qualify for public housing, half are at market rate. All able-bodied persons are employed. And the school is one of the best performing in the state of Georgia, the elementary school, in spite of the fact that 60% of the students qualify for reduced price meals. So what we are saying, it can be done. And the purpose-built model shows we can address the challenges faced by four poor communities simultaneously. We can develop place-based solutions. We can create a cradle-to-college pipeline. Yes, we can develop quality mixed-income housing and affordable low-income households and provide the wraparound services communities need to make a difference. Very importantly, I want to emphasize, the research is clear that if we create these communities of opportunity to reverse racial injustice, it will be beneficial to people of all racial groups. Policies that benefit communities of color will improve the conditions of life and the health of everyone, including many working class and poor whites. So what is holding us back? Since we know what needs to be done. What is the elephant in the room? Why are we not making more progress? I would say there are three challenges we face. We need to raise awareness levels of the challenges. Many Americans are unaware of the extent of inequities. We need also to develop the political will once we know that we are committed to doing something about it. And in order to get to those two, we need to build empathy. That is, how do we tell the story of the challenges of disadvantaged populations in ways that resonate with the public? W.E.B. Du Bois was one of the great African-American scholars of the late 19th century and early 20th century. And in 1899, he published a book on the Philadelphia Negro. And there's a chapter on Negro health that documents these disparities that existed in 1899. And as he came to the end of the chapter, he said the big challenge we face, the most difficult problem with racial disparities, is the peculiar attitude of the nation toward the well-being of the race. He said there have been few other cases in the history of civilized people where human suffering has been viewed with such peculiar indifference. What Du Bois called peculiar indifference, scholars call today the empathy gap. We feel the suffering of people of our own race more than the suffering of people of other races. Here is a study in the United States of mainly white 5-year-olds, 7-year-olds, 10-year-olds. 5-year-old whites, no empathy gap. They feel black people and white people experiencing the same pain. By age 7, there's a tendency to believe that blacks feel less pain, and by age 10, it is pronounced. We need to build a science base that will guide us in how we can talk about these issues, how we can describe them, how we can tell the story in ways that will resonate with the public and will build the empathy and political will. Martin Luther King says, it may well be that we will have to repent in this generation, not merely for the vitriolic words and the violent actions of the bad people, but for the appalling silence and the indifference of the good people. And I say to you today, we can no longer be silent. We cannot be indifferent. Now is the time for us to go to work. We need redoubled efforts to work together to build a healthier America for all. Yes, we can build a healthier America where every child can develop normally, free from poverty, abuse, and neglect. We can build a healthier America where every child can be ready for academic success when they begin school and have access to school environments that support academic, emotional, and physical well-being. We can build a healthy America where everyone can breathe clean air that is free from tobacco and other pollutants. We can build a healthy America where everyone has access to and can afford to obtain nutritious food. We can build a healthy America where everyone has opportunities to be physically active. We can build a healthy America where everyone can live in well-maintained neighborhoods that are safe and that have access to appropriate goods and services. We can build a healthy America where everyone has access to high-quality, affordable housing. We can build a healthy America where everyone has access to reliable, safe, affordable, and accessible means of public or private transportation. We can build a healthy America where everyone has received the training and skills to create business opportunities up to obtain a decent job that pays a living wage. We can build a healthy America where everyone can work in healthy occupational environments, free from physical or chemical exposures that are harmful to health. We can build a healthy America where everyone has access to high-quality medical care. We can build a healthy America where everyone has equitable opportunities and is hopeful and optimistic about the future. We can build a healthy America. Yes, together we can. Thank you so much for listening today.
Well, let me thank you very much, Dr. Williams. I don't know if your ears were burning, but throughout your talk, folks were blowing up my phone and my text messages and saying wonderful things about your talk. You have Dr. Shanita Johnson, you have Desiree Ramirez, Christian Amador, and others singing your praises. They were blown away. So I want to thank you, because you're absolutely right. We have come a long way, but we have to start now to build a healthier country and world. And I appreciate you giving us those evidence and interventions, basically the tools that we need to move forward, right? So thank you again. I always leave your talks feeling much smarter, feeling more informed about these issues. I knew it would have been a special treat for our learners, and I thank you from the bottom of my heart for sharing your words of wisdom with us today. I want to, we're going to continue this discussion. I want to bring in Garth Graham right now, Dr. Graham, and welcome him back for about 25 minutes for a Q&A session. And Dr. Graham is going to help to moderate this discussion with Dr. Williams using some pre-selected questions that we got from our medical justice and advocacy fellows, as well as our political determinants of health fellows, learning laboratory fellows. So thank you to our fellows for submitting those questions beforehand. Dr. Graham, please take it away.
Thanks, Dan. I mean, Dr. Williams is just amazing. The thing that you crystallize for all of us is action. Not necessarily that we need to ask more questions, but that many of the questions have been answered. And the thing is, what do we do in terms of action? So I have a couple of questions here that, as Daniel noted, from some of the fellows that have been working and have a future in health as priorities. I think articulating their vision for how they want to impact the rest of the world. And I'll go through some of the questions. The first one is an interesting one. All these questions I'm curious to know your answer to. But the first question I think speaks to this concept of growth. And let me just read it for you. So, Dr. Williams, your biography and accomplishment speak for themselves. All champions experience hurdles that are difficult to clear, and they often hear the words of people who refuse to support their championship efforts. Where have you encountered unexpected hurdles on the path to your becoming a health equity champion?
Wow, that is a great question. We could have a long answer to that, but I'll keep it brief in the interest of time. I would say that yes, I have encountered in my career people who tell me that we can't study racism. It's too difficult to be measured, and that this is not something that can be done. And so you get people who discourage you, you get people who don't value the work that you do. But I want to acknowledge that throughout my career, I have had good mentors. I have had mentors at the University of Michigan. I have had mentors as a graduate student, Professor James House, Professor James Jackson, early in my career, that have made a difference, and I've had other colleagues that have supported me. So I think there are naysayers, I would say, to any young person, but look to the guiding star and those who have forged their way. And I would say one more thing. Behind me is a picture of the Harvard T.H. Chan School of Public Health. And every day I walk into that building, it reminds me that there are people who gave their lives for the opportunities I have. And I need to make a commitment in my life to make a difference for the next generation. And I think if we think of things that way, we can all make a difference and don't pay attention to the naysayers.
I love that answer. And actually, this next question is I want to answers to all of these questions. So this next one kind of leads from exactly where you just left off, but more delves into how do you sustain the energy. So the question is, how do you do the work of being an advocate and not constantly wear the trauma of the work? That's a good question.
And that's a profound question. Yes, the work is discouraging. There is a study I'll mention that I discovered several months ago, and I cannot get it out of my mind. It's a study that looked at suicide rates among elementary school children aged 5 to 11 in the United States from the early 1990s to about 2015. And what the research found, suicide rates in the United States in these kids was stable. But they were stable overall. They were stable for Asians and Latinos. They declined markedly for whites. They doubled for African Americans. Now, I don't know that when I was in elementary school, I knew what suicide was. And what does it mean that the rates of suicide among Black children in elementary school are doubling in this country? What does it mean to be growing up Black in this society today? And I cannot get that out of my mind, but it doesn't discourage me. It encourages me. And I would tell you that the biggest source of encouragement for me is my students, the postdoctoral fellows I have worked with, and the way they have left me and have gone on to blaze a trail. So I am inspired by what I see so many young scholars doing in the field.
Yeah, you know, a lot of these fellows who have submitted these questions, I mean, I'm inspired by them as well, just because the energy and the passion that they're going to take your work and Daniel's work and many of the work of others, myself and folks who have been doing this work and elevate it, I think is definitely inspirational. So, okay, let's get into some more questions here. Next question is, hearing your TEDMed presentation and reading your research resonates with my path of understanding how racism impacts health. My question comes from seeing the data and reports around the Latinx epidemiologic paradox, which shows Latinx are healthier than the rest of the population, despite their experience of segregation and racism. And the question is, what is your thoughts on that, Dr. Williams? And do you genuinely believe that these populations are healthier than the rest of the population, despite their experience with segregation and racism?
That is a great question. So let me put it into broader context. If you look at readily available national data for the United States, like overall death rates or infant mortality rates, immigrants of all racial ethnic groups have better health than their native-born counterparts. White immigrants have better health than whites born in the US. Black immigrants have better health than blacks born in the US. Latino immigrants do better than Latinos born in the US. Asian immigrants do better than Asians born in the US. There is a healthy immigrant effect. That's the good news. The bad news is the longer immigrants remain in the US, the worse their health becomes. By the way, there is some data from the UK that shows a similar pattern of a healthier profile of immigrants. Well, let's say, how do we make sense of this? A couple things. One is researchers call it a selection effect. The immigrants who come are not a random population from the societies from which they've come. They are persons who tend to be more motivated. They are persons, studies show, who are healthier than their cousins and their siblings who didn't migrate. So you have a healthier subset, and they're more psychologically motivated. They went through the trials of picking up and moving to a new destination. What happens though, so that they come seeing the glass, as I describe in one paper, seeing the glass as half full. Their children, though, raised in American society, see the glass as half empty and encounter those barriers. And so that we see one national study just for Latinos using the NHANES national data found that within 0 to 10 years in the United States, Mexican immigrants have an allostatic load measure. This is a measure of biological dysregulation, similar to that of the white population. By 21 or more years in the United States, they have a biological dysregulation measure that is similar to that of the African American population. So they change within 20 years from a health profile similar to that of whites to a health profile similar to that of African Americans. We found the same in a study I did in Chicago, representative of the adults in the city of population of Chicago. For every outcome and risk factor we've looked at, if we look at Black, whites, Latinos, Blacks are doing the worst, whites are doing the best, Latinos are intermediate. If we break out the Latino population by US-born versus foreign-born, US-born Latinos look like African Americans, foreign-born Latinos look like whites. So there's this dramatic transformation we see. And one of the things that I think is a public health priority is to identify what can we do to stem this downward trajectory of worsening health for immigrant populations in the United States.
It's powerful, especially when you think of what that really was speaking to the lived experience, and how the lived experience really drives these health outcomes more than anything else. All right, I want to make sure I get to all of these questions. The next question is, Is there a difference in levels or type of racism that can result in differing health outcomes?
That is a really good question. I would say the field of racism and research on racism is rapidly growing. We are learning from around the world, collaborating with colleagues on Australia, studying everyday discrimination and its impact on the health of the Aboriginal population, collaborating with colleagues in the UK studying racism. So yes, but I still think it's still in its infancy. If we look at racism and how it functions, the most profound effects, I would say, are the most invisible. I talked about segregation and look at the ways in which it shapes opportunity, but it's beneath the radar screen of our politicians. No, when last have you heard a politician talk about segregation and what it's doing to drive inequities in the United States? And then with types of discrimination, I would say the work suggests that the chronic, ongoing discrimination seems to have a bigger negative effect than just a more isolated, big, acute experience of discrimination, although some of those isolated, big, acute experiences of discrimination, like an encounter with the police, could result in your death. But I think what the research is suggesting that the chronic and ongoing types of stresses seem to have more negative effects. But I think there's still a lot we need to learn, how the structural racism combines with the individual discrimination and how they relate to each other and impact health. I think the jury is still out on the relative contribution of all the various forms of racism.
And one thing you talk about a lot is this issue of how individual day-to-day experiences,
Yes.
a slide here, a disrespectful moment
Yes.
there, where you have to go in a longer line in certain
Yes.
to access certain government services versus depending
Yes.
on where you live. I mean, it's just amazing how these things all kind of tie together.
Yes.
Moving along. Next question is, are we asking and collecting the wrong data, or are there other factors that can neutralize the impacts of racism?
That is a great question. I think there's always been some science. There is literally a growth in science in the area. Historically, the focus of researchers like myself doing work on racism focused on documenting it was a problem. Why? Because people told us we couldn't measure it. People told us it didn't matter. People told us it was unimportant. So we focused our energies on documenting this is real and it has consequences for health. I think there is increasing attention to identifying what are the resilience factors, what are the resources. Our populations are not passive. They are active in encountering racism. Let me just illustrate in the area of discrimination. Research finds, for example, that high quality social ties can break the link between negative exposure to discrimination, experience of discrimination on health. Even the physiological link is broken in some studies with the quality of social ties. A national study of African Americans found that 3 indicators of religious involvement: frequency of religious attendance, social support from members in your church or place of worship, and seeking guidance of a higher power in your daily life, reduce the negative effects of the stress of discrimination on mental health. So those are just examples of research that is documenting there are resources that populations can use that help them cope and that can cushion at least some of the negative effects of the stress of racism on health. And we need more research like that documents the resources and can lift them up so that people can use those resources and maximize them to minimize the negative effects of racism on health.
And it's amazing how some of the resources you describe are innate in the communities, the religious and the faith-based aspect of those things that are there. Just amazing. Next question. Oh, this is a good one. What is the legacy that you hope to leave behind, and what advice do you have for today's trailblazers in their respective fields and institutions that are the first to do this kind of work?
I often end my talks with a quote from Robert Kennedy, and it's a quote in which he says that each one of us can be a tiny ripple of hope, and those ripples can build a current that can sweep down the mightiest walls of oppression and resistance. All I want to be is a ripple of hope, and that I can inspire others to join me so that together we can build a current to sweep down those mighty walls of oppression and resistance.
Amazing. I love that. Next question. Why do you think we've made so little progress in addressing the fundamental drivers underlying the inequities in health impacting our communities?
I mean, it depends on how you look at it. I wrote a paper for the New England Journal of Medicine with Richard Besser, president of Robert Wood Johnson Foundation, and Risa Lavisa-Murray, a former president. And we looked at what has happened over time. We looked at a series of reports from the National Academy of Medicine, the National Academy of Sciences, from the World Health Organization and other organizations. And, we have made progress, and we have to celebrate the fact that we are in a different spot where we were many years ago. The 1985 report from Secretary Margaret Heckler on Black and minority health, the first federal report saying racial inequities in health is a problem that led to the creation of the Office of Minority Health in the Department of Health and Human Services. So yes, I would say for many of our young people, progress is slow, but we have been making progress, and we want to celebrate the progress that we build. I completely agree with the youth. Let us accelerate the progress. Let's accelerate the pace. But let's acknowledge we've come a long way, even though we still have a long way to go.
Good point. How do you suggest we address the reluctance or resistance to medical schools, medical professionals, and health institutions to acknowledge the role of structural racism in health inequities?
To be honest with you, I am encouraged. George Floyd's death has had a significant impact on the conversation about race, about the understanding of race in our society. And I see the CDC and the National Institutes of Health making statements about the role of structural racism, and NIH having new calls for proposals to understand and address structural racism. And across the country, I see healthcare systems, including Rush in Chicago as one example, doing remarkable things in the area of structural racism and coming together to learn and understand what they do. I literally think we are in a moment of change. And what I say to the young people and to our leaders, to use a football analogy, let's not fumble the ball. Let's not waste this crisis moment we're in. Let's maximize the opportunity to raise awareness levels, to tell the story, and to point to solutions so that this can be a dramatic moment of change. And George Floyd's death would not have been in vain.
Yeah. It's to continue your analogy, I think it's time for us to get the ball across the goal line.
Exactly.
Okay, next question is, are there specific equity issues for which you have found that policy has actually not been the best way to address the issue, and where non-policy tools may be more effective? How do you determine which issues those are and which tools can best address them? So I guess the overall question is, are there things where you found that policy was not the answer versus the answer, and how do you determine which issues are policy interventions would be the best versus which issues would be non-policy interventions?
That's a really challenging question for which I don't believe there's a simple answer. I would say that for most challenges we face, we need to take a multi-level approach of thinking at the multiple levels. Things need to be done at the individual level. Things need to be done at the local community level. Things need to be done at the larger geographic political level. Things can be done nationally. Things can be done globally. So I think an approach that says, let's think at the multiple levels at which work and interventions can be done. And sometimes there's a tendency, even among those of us who work in interventions, to privilege the intervention where we have the area of the level at which we have the area of expertise, as if that's the only important area. But let's understand, no one person, no one entity can solve all the problems, but let's think of all the levels at which work can be done, and let us think of working together. And I think that approach is the way I would suggest that we think. No question, there are some strategies or some problems that maybe an upstream policy intervention is the most important, but let's always think of the multiple levels at which we can work.
Perfect. Yep, that's a good point. Last question. How do we frame, this is such a good question. How do we frame the need to address structural racism to those that don't believe that it exists or call it reverse discrimination? And I guess a part two to that, what would be the ideal way to examine policies through an equity framework? So I guess the first part of the question is, how do you frame it to folks that don't believe that it exists or think that is reverse discrimination? The other is, what would be the ideal way to examine policies through an equity framework?
That's a really good question. Both of those questions are really great questions, and I wish I knew the magic bullet. I would say, importantly, that you need to understand where people are coming from. You need to understand what are the dominant frameworks people have in terms of interpreting life, in terms of interpreting racial inequity. So, for example, research finds that most white Americans think, this was work done by the Frameworks Institute, that racism was, and this was done years ago, so in the post-George Floyd and COVID-19 era, that may no longer be true, but it was true then when this was done more than a decade ago, that most white Americans think that racism is a thing of the past at a structural level. That the problems of racism were solved, of structural racism was solved in the 1960s. And that today there is racism, it's only at the individual level, and that, Black people are as likely to be prejudiced as white people, and there's nothing at the structural level, it's all at the individual level. So I think having a conversation to understand where people are coming from, and then in a respectful way, a way acknowledging and respecting the dignity of each individual, not speaking down to people, not attacking them for the fact that they don't have the knowledge you have, but treating everyone with the dignity and grace that they respect. Enter a conversation where we can share and learn from each other and share stories so that people can begin to understand the factors and the forces that are at work. And the second part of the question was, remind me, was how
the second part was around building health equity frameworks, and it was, what would be the ideal way to examine policies through an equity framework?
It's good. I think we need to understand the ways in which inequity exists, and there's so much more data on that. And importantly, we need to put our shoes, step into the shoes of persons in the communities that are most affected, and understand from their perspective what their lives are like, and understand what are the challenges they face. And as we understand where they are and what their challenges are, and ideally working together with them and getting their ideas of potential solutions, can really enrich and inform the science of what we did. Let me just give you one example. The everyday discrimination scale that I developed, and it was so widely used. How did I develop it? I didn't sit in a room and come up with it. I took a shortcut. Instead of actually going to communities and listening to them, well, there were scholars like Philomena Essed and others who had done that work already. So I read Joe Fagan's work and Philomena Essed's work, which were qualitative descriptions, listening to the voices of individuals as they describe the experiences of discrimination they had. And I said, how do I take their voices and turn them into questions? So that general approach of listening to the voices of people and trying to capture their real experiences and let that filter into and help us shape the policies we develop is a good strategy moving forward.
Yeah, it's interesting. In almost all of your strategies, you talk about this idea of bringing in the community voices,
yes,
and having that be a central portion of where we are. So I'm going to end with questions there and bring back in Professor Dawes. But I just want to say, if you look at even just the way you laid things out, Dr. Williams, around career, and it's the kind of thing that I think has motivated many of us to keep moving and to keep biting off what we can chew as we kind of pull together all of those ripples to the JFK example you gave to try to bring down this wall. So thank you for all of that.
Thank you.
And thank you, Dr. Graham. Let me thank both of you once again, to Dr. Graham and Dr. Williams, for such a wonderful and inspirational discussion. And of course, to our wonderful partner, UNT Health Science Center. Thank you both to both of you again, our distinguished honorees, for allowing us into your classrooms today. I had a couple text messages from folks saying, gosh, I'd love to take a class, take their class. So thank you both. And I hope that everyone listening today was able to at least capture one thing, and that is that the pursuit to an equitable America is a marathon and not a sprint. We have only begun to cross the starting line, as you heard from Dr. Williams and Dr. Graham. And as we look ahead and see the Olympic hurdles, we must not lose focus of what lies behind the finish line. So it's going to take, of course, continued and massive efforts, collaboration, synergies, novel approaches, as we've heard, the continued unveiling of the narrative through data, the changing of laws and policies, and many more difficult yet surmountable feats, which is why this award will continue to be presented yearly, to continue to encapsulate and embody the works and efforts of health equity champions and scholars, both domestically and internationally, who choose to run this race and knock down one hurdle at a time. The Garth and Graham Distinguished Lectureship recipient will have shown innovative thinking, demonstrating novel approaches to addressing the political and social determinants of health by employing systemic change at the intersection of policy and equity. Their tenacity to transform norms that have continuously recycled from unjust historical eras is the driving force that will contribute to building a new foundation rooted in equity for all populations. We look forward to seeing you all again next year. Thank you so much for joining us. In good health, I'm yours, Daniel Dawes.